Hi, I'm Paul Sethi. I'm an orthopedic surgeon. I'm sitting with Sanjay Sinha, who is the leading anesthesiologist in the Northeast, if not in the United States. And the topic that we're going to talk about today, or the concept, is post-surgical pain. And the question that I pose, or the paradigm I believe that you intend to set for us, is what if there were, or what if there was no post-operative pain? It seems like a silly idea, and in the world of the post-opiate pandemic world that we live in, it seems to be a challenge. So let's start in the beginning. Where does pain after surgery come from?
So if you think about surgery, it's a trauma to a region of the body. And once you have an injury to the body, there's a barrage of information that gets generated and travels to the brain. And those signals are perceived in the brain as pain. Also, when you have trauma, you have swelling, you have inflammation, you activate the whole inflammation system, and all those things are generators of pain. And so that's how the pain gets generated, and the patient perceives it.
So we sort of believe, or at least we're taught to believe currently, that the acute perioperative pain is a 2 to 3 day window. And in this world of multimodal anesthesia, which is illy defined and not really routine everywhere, there's polypharmacy with preoperative, intraoperative, and postoperative medications and different forms of regional anesthesias. You have developed a revolutionary IPAC, but tell me a little bit about how regional anesthesia has changed, and principally how that interplays with the multimodal concept.
Right. So if you think of pain after surgery, it can be divided into two sort of phases. The first phase is a phase which lasts for about 24 to 48 hours, where you have really intense, very severe pain, and then the pain level starts to come down. The pain levels come down and slowly sort of resolve over a course of days to weeks as tissue healing occurs. That first 48 hours of surgery, or the first 48 hours of pain, can be controlled with nerve blocks and multimodal medications. So this whole multimodal approach is a concept where you use medications and nerve blocks and combinations to try to get the best effect or the analgesic efficacy from these techniques and try to minimize the side effects. And so regional anesthesia becomes part of that multimodal strategy to be able to control pain. And by far it is one of the most effective method of controlling pain after acute surgery.
So really this has been a great setup, because numerous forces have aligned in this perfect storm to bring us to the world where outpatient joint replacement is relevant. And those forces are the economics of medicine, the pandemic where patients don't have the desire to be in the hospital, or the inability to stay in the hospital, and our fear or our limitations were really, at one point we thought maybe we need to give antibiotics for longer, but we've really gotten past that. But the fear was that we couldn't do it with pain control. And at least in the shoulder world, we have this terrible rebound pain, which you've now solved for.
Right.
So I feel like we've moved past this immediate 48 hours. Are we doing reasonably well with the first 2 to 3 days? So
the first 2 to 3 days were the focus for the last couple of years, where we have really honed in on trying to control that acute, severe, intense pain. But what happens is when patients go home, the pain really doesn't resolve. They still have moderate levels of pain. They have exacerbations where with physical therapy or with movement, where they can get intense transient pain. And then the method that is used for controlling that pain for the most part is medications, with opioids forming the cornerstone of that strategy. And to be able to control that pain, that moderate level of pain, while the patient is at home on their own, is what the future is in terms of managing post-op surgical pain. I call this the transitional sort of zone, where you have gone through the window of that acute intense pain of that first 24 hours, but the pain hasn't resolved yet, and you are sort of at home recovering, and it is that days or weeks of pain that has to be controlled really well while the patient is at home recovering.
So as a surgeon, what I'm hearing is you've made my patient's life better in their immediate perioperative period, the first 3 days.
Right.
You've reduced their reliance on opiate medications.
Right.
You've effectively allowed patients to go home post-operatively.
Right.
But now the next frontier is day 3 to day 30.
That's correct. Yeah, and this day 3 to day 30 is a challenging sort of time frame. Just because the patients are at home, you have less communication with them, so you have to have techniques or methods where you can control this with minimal intervention from the hospital setting, from the physician setting, from the anesthesiologist setting, as well as minimal interaction with the surgeon's offices. And so that the technology that has to be developed has to be powerful enough to be able to function independently and be simple enough that the patients can manage it at home.
All right, so you're setting me up. What technology or where is it that you are looking or that you are developing, and where do we go with this?
So obviously there are sort of multiple sort of arenas where research is happening, but the area that I am really interested in is the combination of our nerve blocks and neuromodulation.
So we all know what a nerve block is, right? Neuromodulation.
So neuromodulation is a concept where you electrically stimulate a peripheral nerve that is mediating that pain and confuse the pain signals from going up to the higher centers. So just to give you a little bit of science, pain signals travel through the peripheral nerves through slow fibers. And when you stimulate with an electrical stimulation, you activate the fast fibers. And both these slow fibers and the fast fibers, they actually converge in the spinal cord. And because the fast fibers are sort of transmitting the information at a faster rate, they block the signals that are traveling through the slow fiber or through the slow speed zone kind of.
So you're blocking with the nerve block one synaptic channel,
right? And
with the neuromodulator, you're blocking the second synaptic channel.
That's right. So there are two gates that we have designated. The first gate is the gate where you use medications to control that gate by blocking the receptor sites, while the second gate is controlled by electrical stimulation, and that happens at the spinal cord level and is the basis for the gate theory.
So you thread a catheter.
Right, and the way that we would do it is you place a catheter along a target nerve that is mediating the pain, depending on the location of the surgery, and you can inject your local anesthetic through that catheter to initially create that pharmacologic blockade or the molecular blockade or the blockade that comes from the medications like local anesthetics or Novocaine-like medications. And when that wears off, the same catheter is able to deliver electrical stimulation to block the synaptic gate in the spinal cord. And so you use these two techniques to be able to control that entire episode of pain and comprehensively block that transmission of pain.
And that catheter, that block happened at the same moment in the preoperative area?
Right, so it is the same catheter, it's the same platform or the same catheter that is able to deliver the medications as well as the electrical pulse signal to be able to control the molecular gate as well as the gate in the spinal cord.
So I had a reasonable experience with catheters, but I found that the catheter, if it's dislodged by 2 millimeters or moved a little bit, it would suddenly become dysfunctional. So I have that catheter anxiety.
Right. So in this new catheter that we are developing, which is actually, think of it as a lead with a lumen, we have created anchoring systems that's going to position the catheter in the tissue and hold it in place over a course of 30 days. And then it's going to be taped in such a way that it should not have any kind of movement, and so the malposition of the catheter is going to be minimized. And the other thing is if you have malposition, the electrical pulse that you're delivering to the patient or the electric field that you're generating with your electrical signal can be increased in size, and as long as the nerve is within that electric field, you should be able to stimulate that nerve. And
what's the size of that field?
So it's usually about 2 to 3 centimeters.
So 2 to 3 centimeters.
Right.
So I have plenty of bandwidth for some micro motion of a catheter in theory.
That is correct. And there are studies where these leads have been placed about a centimeter from the nerve and have still provided analgesic efficacy.
So you propose to us now that you've given us effective solutions in the immediate first 72 hours. And now this is a potential solution. Is it for days 3 to 30? Is it only for hip, only for knee?
No, so this is a platform that can be used for any nerve block or any sort of area of the body. So in terms of the upper extremity, for shoulder, elbow, hand and wrist surgeries. For the lower extremity, it could be used for hips, knees, as well as foot and ankle surgeries, as well as soft tissue areas, so thoracotomies, hernia orifices, hernia surgeries. All these are targets that you can potentially use the relay system, the system that we're devising, to be able to control the pain in these locations.
Is there any, I mean, this is amazing, right? So you're saying to me that I'm going to give you pain-free surgery, I'm going to give you better range of motion, my patients will be less fearful of surgery. But is there any data, is there any preliminary data that suggests that this actually could work?
Yes, so there is a lot of interest in peripheral neuromodulation, which has been used for extensively in the chronic pain world, but recently has started being used in the acute post-surgical arena. And there is level 1 data coming out that suggests that using neuromodulation in combination with nerve blocks can decrease your opioid consumption tenfold and significantly lower your pain scores over a course of 30 days. So there is now published data, and we have had some experience doing that as well. That we feel very confident that this is a technique which is a non-destructive, reversible technique that can provide significant analgesic efficacy for the patients.
So that could lead to earlier ambulation and better range of motion in a knee, for example.
So in a small case series that I performed on patients having total knee replacement, what I found was that these patients were about 7 to 10 days ahead of their cohorts who had the standard treatment compared to the patients who had the nerve block and the neuromodulation component.
So anytime you dangle a new technology, and I love new technology, we always concern ourselves about the economics of this technology. And in this world, we're looking to have a more efficient, better value operation. So perhaps you can take me out of the acute care center that I might need after joint replacement. But I'm very worried that is this going to be a very expensive in the picture of a joint replacement? Or are you looking at a lot of?
Yeah, so we have been looking at the economics of reimbursement in the outpatient setting or in the hospital setting for that matter. And what we have found is that in patients that current CPT codes that are used for placing a nerve block, placing a catheter, monitoring those catheters for up to 12 to 15 days, we can use those codes for our system that we are devising. And so it should be cost neutral to the facility and should provide significant value in terms of being able to control the pain over a course of 30 days. So from a patient's perspective, they have a much better post-op experience in terms of pain. From a surgeon's perspective, they get less phone calls, and from the hospital perspective, less ER visits, less opioid-related side effects. So there's benefit all around for all the stakeholders, and the price is still within a range that is reimbursed by current reimbursement CPT codes.
That's amazing. I really look. This is it. The paradigm is changing. If you asked me when I started in practice, can I do a joint replacement as an outpatient? Can I send them home the same day, and can I have them opiate free? I'd have smiled and be like, look, that would be a fantastic idea. And now it's 45% of my shoulders will go home and be opiate free through the entire experience. So now you're extending this out to 30 days. This is the future, and it's here now. Yeah,
it is. And from a surgeon's perspective, it is really, really critical that the surgeons have the confidence to be able to do a complex procedure in an outpatient setting or even in a hospital setting and send the patients home right away and be confident that the patient will have great pain control, great patient outcomes, as well as satisfaction in terms of the recovery process, and not bounce back to the emergency room for pain-related.
Which, by the way, is horrible. It's horrible for the patient. It's horrible for the episodic care. It's horrible for the cost, and it's horrible for your doctor's reputation.
Right. And so this system really sort of benefits everybody in that process of providing great care to the patients, having a great experience, and having great recovery process after the surgery.
Well, I'm very excited to see this develop. Thank you so much.
Thank you very much. So you can gather objective information in terms of distance walked or falls,
and how mobile
the patient is.
Yeah.
And then the app can also serve as a communication tool between the hospital, the physicians, and the patient.
Fantastic. So Sanjay, we've come very far in perioperative pain management. We're successful as outpatients. What is the next step? What is your approach?
So we have created a device called Relay, and it's a platform that combines nerve blocks and neuromodulation into a single device whereby you can deliver nerve blocks, local anesthetics to create a nerve block, and electrical stimulation to create a neuromodulation for controlling pain.